go ahead and, Laura, if you're okay with them recording this, we'll let them put that on their database so we can, and then take it away.
Okay. Are you guys seeing the just the screen itself, just the one slide, or are you seeing like the next slide thing as well?
No, we're seeing your next slide. We're seeing it's in presenter mode, but we're seeing sort of your next slide as well.
Yeah, this is interesting. Stand by 1 second. See if I can because I don't want the next slide to give some of the things away. One moment.
I think if you're in that mode, Lori, there's a little prompt at the top you can hit there.
Yeah, or if you just click slideshow, I think instead of presenter view, that should work.
Let's see here. Stand by. There's that. Oh, I think it's because we're using the two screens. Stand by. All right. I know what's going on. There we go.
Yeah, Laura,
Okay.
I think oh, there you go. Oh, that looks great.
Good.
Perfect.
All right.
All right. Thank you.
Thanks for standing by during the technical difficulties. Okay.
No problem.
Moving on. So, these are going to be several case studies. These are all from patients that I actually saw throughout my externship for audiology. And some of them are going to be kind of abbreviated cases. A lot of them were vestibular heavy. So I didn't want to bring in confusion. I just wanted to keep things simple. So quick refresher, our goals for diagnostic testing as audiologists, assessment of hearing sensitivity, middle ear function, and outer ear status, evaluation of ear-related symptoms with the patient and their potential impact on their quality of life, such as hearing loss, otalgia, oral fullness and pressure, tinnitus, dizziness, noise exposure, any and all of those red flags that we're kind of looking for that may need, further treatment and consultation with ENT. So jumping right in, first case, 79-year-old female. This was at a private practice rotation that I had, and she came in with the chief concern of a hearing aid retention issue. She wanted new hearing aids because the ones that she had wouldn't stay in her ears. Well, the left one fit okay, but the right one wouldn't stay in her ear very well. So overlooking and asking her case history questions, she denied oral pain, pressure, and fullness, no dizziness or balance issues, no noise exposure, hearing loss. But then she stated she had a history of 2 very complicated ear surgeries on her right ear performed by different surgeons at different hospitals many years ago. She was a poor historian, had no idea what type of surgery she had and when they may have taken place. So what do we do first after case history? Otoscopy, always, 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 before we get to anything else. You want to look in those ears, even if you are the 5th person to look in those ears today, right? So her left ear looked like that. Okay, perfect, normal. This is lovely. Her right ear, and this is actually from a video otoscope at the private practice I was at, looked like that. So there was not an eardrum or anything to be visualized. In fact, the speculum of the otoscope went in maybe a couple millimeters and hit against soft tissue. And as a burgeoning third year, I was mystified. What is this? So obviously I wasn't able to do tympanometry for that right ear, but the left ear was a type A. So we have our left audiogram, if anybody wants to describe it for me.
Okay. So it's a mild sloping down to severe sensorineural hearing loss on the left.
Excellent. Yes, absolutely. And then our right ear looked like that.
So that's also a severe sloping to profound mixed hearing loss on the right side.
Excellent. Yes. And what is missing from that audiogram?
Well, the speech reception thresholds, and I don't know whether we want to add the tympanometry as well.
Yes, so there's not any speech reception thresholds on this. This is actually missing on the right ear 6,000, 8,000 hertz. The audiometer there didn't actually put in no response signal, so it was handwritten at the bottom. So if you notice, it only goes from 250 to 4,000 on the right, and then the left ear is 250 to 8,000. So a lot of these cases are different audiometers or handwritten audiograms, which I think there's merit to learning because there's all different types, and you're going to see all different things and have to be able to decipher it. So yeah, just a little caveat there. So no response, and it was handwritten in. So the outcome to this, we didn't know what we were looking at that point in time. So she was referred to ENT because I couldn't dispense hearing aids because she wanted RICs for someone that didn't have an ear canal. So she was very upset and stated that she was in fact very upset. And later on, found out that this was actually an overclosure. She'd had, and her right ear had been overclosed, and it was kind of loosey-goosey because she'd been trying to push a hearing aid into that for quite some time. So it was quite the case, but it was a good learning experience because it's something that you will see. Raul, I mean, I think it would be more often seen in a larger medical center or research hospital or university. You will see those things out in the wild, even as a private practice audiologist. So it definitely was a good learning experience for me as a third-year student at the time, never having seen anything like that before.
2 questions, if I may.
Sure.
One question is, when you were doing your otoscopy, did it look just like a smooth end pouched, or was there, I couldn't tell right around the outer rim if maybe there was a little cleft that went past that point, or was it just nice and smooth?
It was just nice and smooth.
Okay, thank you. And the other question was, you mentioned RICs. What is that, a abbreviation for a type of a hearing aid she wanted? What is a
Yes.
RIC? What's a
Yes,
RIC?
I'm sorry. Yeah, so a RIC is a receiver in the canal hearing aid or receiver in the ear. So the body of the hearing aid sits behind the ear, and you have a thin receiver wire, and then the receiver goes actually in the ear canal.
Okay.
So that's why she was having retention issues. She was trying to push something into an ear canal that wasn't there.
Thank you.
And Lori, sorry to interrupt you too. I want to just, so Louisa, Peter, you guys, have you seen some ear canals that have been overclosed? Have you ever seen anybody in the clinic or actually seen that surgery performed?
I've seen 1 or 2 that came from other institutions.
Mm-hmm.
And I mean, in terms of overclosure, I can only really think if we do a subtotal petrosectomy that you've obviously closed the canal, but so that I've seen here, but not very many, to be perfectly honest.
Mm-hmm. Yeah, occasionally we have to go close the canal off for things like if they've had a lateral temporal bone resection, they no longer have an ear canal, but the meatus was free of tumor. Sometimes if they have CSF leaks or really bad disease, or sometimes if the ear is so chronically damaged, maybe from infection, trauma, etc., that maybe they get a cochlear implant, but the native drum is not healthy enough to be trusted to seal off or protect a cochlear device electrode. So many times you have to clean out the ear canal, take the drum out, maybe put an implant in, stage them. Sometimes you overclose everything. Obviously, there's a higher risk of cholesteatoma with that if you trap skin behind. But there are several indications that we overclose the ear. So yeah, and I think what Lori's take home there is really smart and wise is that it's kind of that old intern dictum where you trust no one. You have to look at everything and double check on your own, make sure that what people may have reported is actually true. And so really looking closely at those things. So yeah, sorry to interrupt you, Lori, but just a little comment there because we don't see these too often, but there are definitely times in the ear canal overclosure is warranted and it's a good thing.
Absolutely. And no worries about the, you're not interrupting at all. All really great points. All right, moving along. So
one that I did see had been labeled as a featureless eardrum by the preceding sort of doctors that had seen the patient. So yeah.
And sometimes patients may not be aware that that's been done. So she may not sound like she may or may not have been aware of what was actually truly going on in her own ear. So being as clear as you can with patients that can never be overestimated about clarity. Just being very clear about what's going on, because some folks they may not grasp that concept and may be confused down the line.
absolutely.
Previous physician was right. That was a featureless eardrum. If there was no eardrum there at all, that was completely featureless.
Yeah, and one more thing too, sorry, Lori, but as audiologists, we know we see a lot of older adults too. And so dementia can definitely be present. People don't know their own history sometimes. So you just have to take everything kind of at face value and put the pieces together like Lori mentioned.
And yeah, Andrea actually just took the words out of my mouth. I do believe with this patient, sadly, that there was a bit of cognitive decline there. Just because, like I said, she was a poor historian. So trying to get any history out of her at all was rather difficult. But interesting case nonetheless, an interesting audiogram. All right, case number 2. So this is a 71-year-old male. Chief concern, new onset of progressive dizziness and nausea. It's 1 month post-COVID-19 infection. He was blaming it on COVID-19, right oral fullness and otalgia. So his right ear was painful. Otologic history, noise exposure from factory work as a teenager. Did have a history of vertigo from BPPV, and he was considering hearing aids. His wife wasn't happy and thought that he wasn't hearing very well at home. So after otoscopy, what type of tympanogram do we have here?
AD. Type AD.
AD?
Yes.
Yes, correct. Knocked it out of the park. And if you look at the bottom below the tympanogram there, were we able to get acoustic reflex thresholds?
No.
Correct.
No.
It's artifact. Yeah. And why do you think that with a very deep type AD tympanogram, why would it be difficult to get those reflex thresholds?
Well, I'm just wondering whether was it like the patient had some trauma or something that was disrupting the stapedial reflex, right? Because I'm at a loss. I don't know. I'm just wondering why, but maybe my colleagues can help. Because the AD should suggest ossicular disarticulation or dislocation and no reflexes. Well, I don't know.
Yeah, so and my apologies, I'm struggling to hear on my computer. So yeah, so when you have a really deep type AD or AD in general, you have a hypermobile eardrum, right? So it's really moving from that testing. So when we put in that sound, we got very excessive artifact. That eardrum, the sound to test the reflex, that eardrum was moving all over the place. So it was very hard to be able to measure those reflex thresholds and patterns. So it was just unable to be measured. But yeah, and I mean, it could be hypermobile for a lot of reasons too. All right.
Dr. Appia Thompson's comment was a good one, that it might be that there was some, if they'd had something done that had severed the stapedial tendon, or that gave them hyperreflexibility and also lack of response. That would be another way that could happen if they've ever had any surgery or anything that might have done that.
Absolutely, absolutely. I just realized my slides are out of order. So we're gonna ignore 2 slides really quick. We're gonna go to his audiogram first. All right. Audiogram looks like this. Mind you, his wife was upset that he wasn't hearing well at home. So who would like to describe these audiograms?
Yeah. So for the right ear, we've got a normal hearing sloping down to profound, and on the left we've got normal hearing over the lower frequencies that also slopes down to a severe, or we could say profound, hearing loss.
Yes, excellent. Absolutely, 100%. You guys I'm making these too easy. I'm gonna make them a lot harder. And on this audiogram, do you see anything that's missing?
Basically the bone conduction. Yeah, I mean, we don't have bone conduction at all the frequencies.
Yes, yes. And so we know that, once again, this is the type of audiometer that it doesn't, and this institution did not like to see the no response symbol. So it's written down at the bottom that, there is no response at 8,000 hertz. And then if you notice, there's no bone response at 4,000. We have the little unspecified ear carrots at 500, 1,000, 2,000 hertz. There's no response at 4,000 hertz because we were at equipment limits. So just all those little kind of Where's Waldo things that, we look out for, because it's like, wait, what is it missing? Where's the bone response for 4K? They were at equipment limits, and this does not actually draw out a no response symbol. So.
Question. It seems to me that would not be at the equipment limits. I mean, maybe that's what they said, but it seems to me like they just didn't do it because that's not really at the equipment limits for most audiometers at that bone level, wouldn't you say? At 4,000 hertz, or 4,000, or at 4,000. I'm sorry, not I was looking up at 1,500 where they hadn't done it. So
Gotcha.
1,500, I was thinking, they just didn't measure bone at 1,500. Is that correct?
Correct. Yeah. The
Okay,
standard
right.
for at this institution was to do 500 hertz, 1,000, 2,000, and 4,000.
Gotcha. Okay, sorry.
No worries.
Okay.
So this patient with that right fullness and painfulness in that right ear, what ended up happening to him? Well, the outcome of this case is that he ended up presenting to the emergency department about 6 hours after his audiology test and his appointment with the ENT there with a right-sided facial droop. So stroke was ruled out during the consult in the emergency department. He was ultimately diagnosed with Bell's palsy. So ear discomfort had resolved by that time, but his right lip felt numb and facial weakness was observed in the emergency department. So he was given a prescription for Valtrex. He didn't end up recovering, which is good. And he was actually not given a steroid taper because of health conditions that he had that contraindicated that. And he did end up pursuing hearing aids, I'm sure much to the delight of his wife at home. But that being said, to kind of loop back around, if we had gotten acoustic reflexes, that may have ultimately been helpful to kind of point us towards that. But we weren't, because he had very hypermobile, very deep type AD tympanograms. But if we were to do acoustic reflexes, what pattern do you think that you would see? And I will go back to that slide really quick. Not realize that they were out of order. So there is a normal reflex pattern. And it was the right ear that was involved.
Well, look at the pathway. So in essence, so if it was his right ear, sorry, there's a few things that don't really make sense to me. Just, sorry, I'm just trying to piece it together. But he had progressive kind of symptoms of vertigo for a while, I presume, which would be very unusual with the bells. Sorry, I'm just thinking. So I don't quite know how to correlate. I mean, I understand the question. I don't know quite how to tie it in with his Bell's diagnosis, if that makes sense. Because if it was progressive for a while, yeah, I mean, I don't know. It's just my sort of thought off the bat. But if it is right ear, obviously your response coming back by your facial nerve, you would have an absent reflex on the same side that you are applying, the same side that you're testing the reflex on. And then obviously because of the crossover, you would have an absent reflex on the contralateral ear if he had a middle ear effusion or something else to explain his atologia at the time. So it's just about what signal's getting in and whether or not the facial nerve can produce the reflex response in the contralateral and same side. So I guess it's just because to me his history doesn't really make that much sense. So yeah, I would just be looking for other things at the same time.
Right. And I realized that with that history, it was kind of interesting. It's interesting how things developed. Now the dizziness, I don't know if that was just incidental, if he had something else going on. But when we are gathering that information, we are all thinking, what could this be? What's causing him to be dizzy? What's causing one-sided pain, or what's causing one-sided tinnitus? Or, so we're, as we kind of delve deeper and peel back, the layers, then, typically, what's going on with that patient becomes a little bit more clear. He was not straightforward at all. He was just very complex. He had a lot going on medically. But I do think that it was interesting, and I do, wish that we would have been able to get that reflex pattern, because I think ultimately it would have been helpful. Particularly the fact that he was coming and complaining of right-sided otalgia and fullness. But yes, so on the right side, you are correct. It would be the right ipsilateral reflex that would be inhibited with Bell's palsy, and the left contralateral. So really good job. Awesome.
Can I just ask a quick question?
Sure.
Maybe this is a good one for Dr. Basura. Do you typically see pain with Bell's palsy? I imagine you can, but you also think of other things as well? Was this, it sounded like fairly severe pain that he was having?
Fairly severe pain, yes. He came in and we could barely touch his ear to perform otoscopy. So that may be a really good question for Dr. Basura. I have not honestly seen, as a newly graduated clinician, that much Bell's palsy. So
yeah, I mean, they certainly can. I mean, the prodrome to that, oftentimes they'll have taste disturbance. They can have changes in hearing if the reflex is now being blunted. With the innervation of the ear canal, there's some innervation of 7 in the ear canal. They can have some discomfort in the ear. We don't see a lot of it either, right? Most bells go to the ER or they go to their primary doc. And as we know, most recover. Even if you don't treat them with steroids, which, this was an interesting treatment because, the Bell's palsy guideline would suggest that, antiviral as a monotherapy is really not indicated. But the natural history of Bell's is that most, over 80%, will resolve back to a normal or like a house Brackman 1 or 2 on their own. But we don't see a lot of it. Now, Ramsay Hunt, right? Herpes zoster oticus, that causes a lot of pain, but that's not Bell's palsy, right? That's a different thing. That is certainly where zostercidal antivirals are indicated for a good 10 days, high dose steroids. Those folks definitely present with pain. And unfortunately, they have a lot of post-herpetic neuralgia. So they have, even after they have the treatment, they have a ton of pain residually. But Bell's is not as much. So again, that could have been historical sake. Maybe he had other issues going on. What's the most common cause of ear pain, guys? If somebody comes in and says, "Oh, my ears are killing me. I've got this pain in my ear." What's by far and away the most common cause of otalgia?
Prof, I'll think of some infection like an otitis externa, otitis media acute.
Mm-hmm. Let's say, what if it's in the absence of any ear findings? What if you look in the ear, there's no periauricular, auricular swelling, ear canal, there's no edema, there's no evidence of like an otitis externa, drum is completely normal, there's no fluid. So in the absence of ear findings, what would be the most common cause of ear pain?
TMJ dysfunction.
Yeah, it's usually referred otalgia, right? It's usually a dental source, TMJ, malocclusion, what we call bruxism, clenching or grinding of the teeth. So you always want to look at the jaw, just because of the common shared innervation. Then also the posterior oral pharynx, right? You want to look at the oral pharynx, make sure they don't have something brewing in the oral pharynx that could also cause referred pain. But to answer your question, Brad, I don't see a lot of that ear pain, so that may have been a bit of a red herring for this patient.
I wondered if maybe even it was an early herpes zoster oticus just because of amount of pain. I had a herpes zoster oticus one time myself, and I was shocked at how painful it was. I couldn't touch the hair on my tragus without it feeling like an ice pick, and so somebody's got exquisite sensitivity. I think of something like herpes zoster oticus, but they didn't have apparently no blistering lesions or anything that looked like vesicles, and so may not have been, but maybe that developed later on as they went on to develop their palsy too. So I maybe that the antiviral was exactly the right thing to put them on if it
could have been. Yeah. And unlike Bell's, herpes can cause the herpes zoster oticus can cause profound hearing loss, and hearing obviously can be highly affected. Whereas Bell's, there really is no associated hearing loss. Yeah.
Right. Yeah, this one was a mystery to me as well. And I did think it was funny at the time because I was like, were they thinking it was Ramsay Hunt with the Valtrex? But then reading more, he had a lot going on that he could not take a steroid taper. So I think that they were like, well, this might be the next best thing. We'll just cover all of our bases. All right. So case number 3 was a 22-year-old female. She came in with a host of issues. She was having tinnitus that was louder in the right ear than the left, right oral fullness, pressure, otalgia, changes in hearing sensitivity. She felt that her hearing had decreased in the right ear far more than the left. And she was having discharge from both ears with a greater amount of discharge from the right ear than the left. She did have a history of otitis media bilaterally. No ear surgeries, no vertigo, no family history of hearing loss. So what type of TIMPs do we have here?
The right one is B, and then the left one is A, or no, A, type C, maybe.
Okay, all right, yeah. So left is definitely A, and right I think it's interesting that you called it a C because the audiologist that performed this first set of tympanograms also called it a C. So awesome. Really good job. With that one, with the right side, I could see the argument for both ways. Some audiologists would call it a C, right? Because it's definitely negative pressure. Some would also call it basically flat. So it really is, it's interesting how different providers and different trains of thought kind of interpret things. But yeah, you knocked it out of the park. That's awesome. All right, and describe that tympanogram, it's the handwritten one.
So for the right ear, it's a mild conductive hearing loss, basically. And then the left is normal threshold. Yes.
Absolutely, yeah. Once again, knocking it out of the park. So that left ear is normal hearing sensitivity across all frequencies tested, and the right side is a mild conductive hearing loss. And she ended up having some ear surgery. So this set of tympanograms is after surgery. What do we have here?
Left is C and right is
AS.
Yes, yeah, good, yeah. And for the left, I think they ended up calling that an A, but once again, that goes with clinic norms and different ways of thinking. I can definitely see the argument for calling it a C because she does have negative pressure. At this particular clinic, it was for adults, they had to have negative pressure greater than 100. So if she was at 101, they would have called it a C. Because she's at 85, they ended up calling it an A. But I have also worked at places that 85 was certainly negative pressure for an adult. And yes, so that after surgery, she does have a type AS. You guys are rock stars. This is great.
So
Okay.
Lori, sorry to interrupt you guys, a quick question. So if you saw that first tympanogram, and this is for Peter or Louisa, is, if you're trying to figure out between like a type C or a B, is there anything else you might see on that tympanogram that might tell you that it could be one or the other? What else does a tympanometry give you that could suggest something else about the state of the drum?
Well, you can look at your ear canal volume. So if your ear canal volume is very large, you would think that maybe there's a perforation and that's accommodating a larger
Right.
volume in the ear. Whereas if there's an intact retracted sound drum, you wouldn't have as large a value, as large a canal air volume measured.
That's right. Exactly right. Yeah. So that's an important thing to look at. And I don't know if both Andrea or Lori can comment on this, but are there times that you've experienced where the ear canal volume can be misleading? Like, sometimes if they've had surgery and they've repaired a perforation, you might still get large canal volumes. Have you ever seen that in the absence of a perforation? Can you explain maybe technically, sometimes it could be misleading that it says larger canal volume, but you look in the ear and there's no perforation?
I've seen, sorry to jump in, Laurie, and if you have something to say, that's fine. But especially with like a canal wall down surgery, I mean, that as expected, you're getting kind of an enlarged ear canal volume, but you can have still intact eardrum and you see a peak. So I think the first time I saw that, I was kind of wowed. The other thing that can change too is if you're seeing like a really low ear canal volume, you might just not have the probe tip correctly in the ear either. So ear canal volume can definitely clue you in. Also, it can help you see whether there, is a monomere in the eardrum versus a perforation. The other thing I wanted to comment on this too is I have seen people describe tympanograms as type CS, which is negative pressure and also low admittance. In this case, sometimes the tympanometer picks a peak and automatically picks the admittance for that. So we also have to make judgments as an audiologist. Hey, is that a peak or am I going to describe that as type B? So that's kind of up to our discretion as well.
Thanks. Thanks, guys. Sorry, Lori. Thanks.
Oh, you're fine. You're fine. So this was post-surgery, and then this is her audiogram post-surgery. So who would like to describe these?
The left is normal hearing thresholds. The right ear, has a conductive loss, a mild conductive hearing loss, and up to 4,000 hertz, and then beyond that becomes severe. So basically it's a conductive hearing loss, but it starts in a mild conductive loss and then slopes down to a severe loss in the higher frequencies.
Yeah, absolutely. I love how specific you were with the frequencies as well. That is how it was described. So yes, absolutely. And she did have good speech clarity for her word reception scores. So with this outcome for this 22-year-old patient, after surgery, and she did have a mastoidectomy, canal wall up, she noted she wasn't having any pain or fullness or any more infections, which was good. And she did have an infection in between the surgery and when that last audiogram and tympanometry was completed. She had been putting Q-tips in her ears and ended up with a fungal infection. So she was warned about the ills of sticking things in her ears. But she came back, that had cleared, and those were the results for the audiogram and the tympanometry. And so once everything was cleared up, she wasn't having difficulties discerning speech. She did still notice a decrease in hearing sensitivity on the right side, which is reflected in the audiogram. So that was just kind of confirming what she already was perceiving. She wasn't interested in amplification because she did say that she was noticing a difference between the ears, and there was a difference, particularly at 6,000 and 8,000 hertz. She actually asked for a second look or revision surgery, and the ENT disagreed with her because she finally had a clean, dry ear. So it takes all kinds. Patients are very interesting as to kind of the information that they hold on to sometimes. So yeah, she was
Lori, do you know if she had a cholesteatoma? Was this cholesteatoma,
or yes, she did.
Or did she have vesicular chain reconstruction, or was there anything that? Okay.
Yes, this was a cholesteatoma.
Yeah. So, personally, the patient, I think, is very intuitive to know that may need a second look. If it's cholesteatoma, oftentimes that's warranted. Just again, that's just obviously depends on the practice and what you can see and your concerns about recurrence. And then, so an interesting question for you guys is, if you have cholesteatoma and they go into the OR with a specific hearing level, and they have maybe some mixed component or conductive component, and then after surgery, that conductive component is worse, is there any explanation for that? We may have talked about this before, but Peter, what do you think? Is there, the patient said, wait, I'm not hearing as well now, and I thought you did surgery. Why am I hearing worse than I did going into surgery?
So, Prof, it's likely the cholesteatoma was bridging the gap between the ossicles. When it's taking out, then the hearing can get worse.
Yeah, that's absolutely right. I know we talked about that maybe before. So I think it's important when you are counseling patients about surgery to kind of give them that expectation that if you are maybe planning a second look and you may do a delayed vesicular chain reconstruction, I know there's variability on how people approach that. Some people will reconstruct the ear bones at the same setting. Some will do a second look, or there's a mixed bag of that practice pattern. So depending on what the needs are, you want to make sure the patient's aware of that, because that could be a little disheartening for patients, and they wake up like, wait a minute, after they've healed, like my hearing's worse. Why is, I thought you fixed the problem. Why is this worse? So, so it's a interesting dilemma that patients may not be aware of.
Could I just make another point too? Do you mind showing the first audiogram, the pre-op audiogram?
Sure.
Yeah. So, and if you show the post-op, you've got that new high frequency hearing loss in the right ear that almost looks like noise trauma, where you've got the dip and then it recovers a little bit. So one of the things that we think about if somebody's had a mastoidectomy, particularly the short process of the incus where it comes back in the additus, if the drill touches that, it can give them a high frequency hearing loss. So that might be surgically induced and something to be cautious about when drilling the mastoid on a patient.
That's an excellent point. All right. Case number 4. I have 5 cases and the last one's very short, but number 4. So this is a 54-year-old male. Chief complaint, left-sided only tinnitus that began 3 months prior to his first visit with ENT, which was in June 2020. So his tinnitus started right in the middle of the COVID-19 lockdown, March of 2020. He described it as high-pitched ringing, intermittent episodes of oral fullness in that left ear, no right-sided tinnitus at all, and had not noted any changes to hearing sensitivity. So right there, big red flag, right? Otologic history, no dizziness, noise exposure, or familial history of hearing loss. So these are his temps. Very self-explanatory, but if you guys want to shout out what they are, that's great too.
Normal.
Absolutely. Yep, type A. This is his hearing loss in June of 2020. What do we got cooking here?
The left ear has normal hearing thresholds up to 1,000 hertz. Then beyond that, we have a sensorineural hearing loss which is sloping through to it's normal and then it slopes to severe.
Yes, absolutely. Absolutely. And that right ear obviously is normal hearing sensitivity. And he's got pretty good word rec. So what happened with this patient? So fast forward to June of 2022. This patient ended up being diagnosed with a left-sided intracanicular vestibular schwannoma. It was 7 millimeters. And he and his wife, after consulting with the ENT in the practice, decided to kind of watch and wait. They wanted to not go for surgical intervention, and the ENT was in agreement so long as there were no changes in size to the tumor. So they had been kind of monitoring him every 6 months with some form of imaging, and 2 years later, it had not changed at all. This was his hearing. So once again, very much the same pattern. Right ear is normal, left ear is normal through about 1,500, and then it slopes back down. Interestingly enough, with that left ear, he did have a collapsed canal, if you notice, or kind of like a collapse-y canal, but the first one was done with TDH. And you notice that at 6 and 8K, he's down there pretty far. He's definitely into the severe hearing loss level. With an insert with that canal held open, it brought it back up. So he's really only in that moderately severe. So that's
or even when you define what TDH is, I'm sorry, what's TDH?
Oh yeah, so TDH is over the ear headphones, right? So they're great for avoiding like the occlusion effect with an insert, because sometimes when you put in an insert in the patient's ear, the different transducers, what it will do is in your lows, you'll see inflated values in the lows. So instead of like, let's say the right ear being at 10 decibels, because you have that insert in there plugging things up and potentially rubbing against the ear canal, and not all the sound is getting through as it should. So they'll be responding at 20 or 25 decibels instead of 10. So that can happen with inserts and lows, but what happens with the TGH phones, the big headphones that go over the ears and the highs, is if you have people with kind of like very narrow canals, sometimes it'll just collapse them shut. And so it won't you'll see it in the high frequencies. And that's also something that happened with this patient. That was just kind of interesting, just a little nuance thing. When I'm doing otoscopy, I'm very aware of whether or not I'm seeing that, canal. Does it look really narrow? Does it look kind of like it's going to collapse if if there's pressure put on that? So I typically use inserts for that reason. And then if I have to go back and check, 250 to 1,000 hertz with TDH, headphones, I certainly will. But yeah, that was that was fairly straightforward, but it was
Did you
just
get reflexes on this patient? And what
no.
would you expect, guys? What would you expect reflexes to look like if he had maybe an intracanalicular schwannoma in the left IAC? I know they're not here, but can you maybe predict what they might show?
So the ipsilateral reflex should be absent, but the contralateral will be present. I don't know what you can consider absent.
They will be absent.
Bilaterally.
It should be absent.
Absent bilaterally.
So if you did a stimulation left and a probe right, so you're stimming the left ear and you're recording from the left ear, what's it going to show, do you think?
So it's going to be absent on the left.
Okay, what if you stim the left ear and you probe the right ear?
It's still going to be absent.
Could be, yeah. And then what about stim right, probe right?
So if you stim right, probe right, it will be present.
And then what about a stim right, probe left?
If you stim right, probe left, it will be absent.
Yeah, it's possible, or they could have elevated thresholds, right? May not always be that clean, but there could be something of that nature, right? But either way, tip-offs are unilateral tinnitus, right? And then the other thing too, Laura, I didn't get from the history, was that a sudden hearing loss or was it a progressive?
So he had actually not had any complaints or perceived hearing loss. It was just the tinnitus, just straight ringing high-pitched tinnitus in that left ear.
Oh, got it. Yeah. And another thing, guys, too, is on the audiogram, even before you had say you gotten the MRI, it doesn't show it on this. But what's another tip off of maybe retrocochlear pathology that you might get on an audiogram that this patient didn't show? Sorry, I know it's kind of what am I thinking sort of question, but
I know what he's thinking.
If you're
fine.
If you're looking at an audio and somebody unilateral tinnitus and maybe an asymmetric sensory neural hearing loss, what's another piece of information you could look at and go, yeah, that looks like classic, maybe retrocochlear pathology. We definitely need to try.
If you have rollover.
Okay, what's rollover?
So basically, if you look at your speech reception thresholds, if you have a retrocochlear pathology, you will be able to reach a certain level, but after that level, once you reach a certain threshold, that level will then begin to decline, versus a sensory neural hearing loss or a conductive hearing loss, where if you amplify either of those, your SRTs will actually improve. They won't necessarily decline.
Okay, so what about the word discrims?
Yes. Yeah. So
And how those are perceived with the speech reception threshold. What might be?
So speech discrimination is disproportionately worse versus your SRTs, in essence. Your speech discrimination worse than, you know, actually just being able to detect the words.
Right. So the SRTs may be intact many times, right? Or normal, or not different, not asymmetric. But you may see asymmetric word descrim, right? So that may depict that you may have some kind of retrocochlear pathology. So there's oftentimes a preservation of the SRT, but the word descrim may be different. And it depends on different places. Brad, I'd be interested to hear what you do for descrim difference that would warrant an MRI in the absence of any ear symptoms, say, for example, tinnitus, for example. Some people use 10 or 12% differences. I'm pretty conservative. If they have for me, that's usually what I do. If they've got more than 10% difference in word descrim, that for me is enough to warrant an MRI. But I know that speaks to our medical legal climate here a bit more than probably the realities of the situation. But Brad, what are your thoughts on descrim differences?
So that's a complicated question in our institution. We have a nomogram that kind of shows the critical limiting difference, and it's not a single level. So if you're at 100%, the difference may have to be only 12%, but if you're at 50%, it might have to be 20% difference. There's a critical limit, and so we actually on our audiograms have this graph that shows, you know, where their discrimination is, and it's very complicated. I've never liked it very much, but I understand the principle behind it, and that is that you at certain speech discrimination scores, you have to show 20% difference to be significantly different. But from a medical legal standpoint, you know, you're kind of covering yourself if you look for a 10% difference and go ahead. So yeah. Can I make one other unrelated point too? And that is that during the middle of COVID, you know, we saw a lot of people who came in and were concerned that their hearing loss was COVID related. And we had about half of them, there's a case series that was reported with about half of them that had asymmetric hearing loss differences. So it certainly could have been COVID related, as you mentioned early on, right in the middle of the COVID crisis. The inner ear does have angiotensinase receptors, which are what the virus attacks in the lungs and so forth as well. And so we know these ACE2 receptors make it more prone, particularly in a little bit in the Schwann cells, but more in the neural cells that can get COVID infection, and it can be unilateral. And it's about half the time it was unilateral, half the time bilateral.
All right. Well, I hate to run. I actually have a 7:30 patient. I just realized it was 7:22.
Yeah. Okay.
Sorry, I just messaged you, but I can start the clinic day if you want to finish up this discussion. I mean, it's been really good. I know you have one more case in a few more minutes, so I can take that first patient and you can finish up if you want.
Okay, if you're willing to do so,
Yeah,
then
absolutely. I think I don't want to disrupt this, so and we have the staff for it. So thank you. You're doing great.
All right, last one, and this one's fairly simple. It's more just about the tympanograms than anything, just because this is an unusual one to see. So this came from one of my pediatric rotations, and we already talked that he was going to watch and wait for that schwannoma for the outcome for case 4. So case number 5, 5-month-old baby, failed newborn hearing screening in the left ears, failed for both AABR and DPOAE. We're not going to get too far into ABR stuff, and I know that we just Andre briefly mentioned in the past couple of weeks about otoacoustic emissions. And otologic history is very simple for this little one: full-term pregnancy with mom, normal delivery, no complications, no familial history of hearing loss. So this is actually the DPOAE refer report. Left ear is referred, right ear is passed. If you look at the bar graph, you can see that those signals for the left ear are basically knocked out. I did include this because it was fairly easy to read. It's from a more well-known health system in mid to northern Michigan. And I do like the fact that they just had their pass criteria over to the right-hand side. 3 frequencies to pass, minimum amplitude is listed and signal to noise ratio of 6 decibels to pass. So right ear is passing with flying colors, left ear, not so much. So this is this baby's tympanograms the day of the recheck with that DPOAE screener where they referred in the left. What type of tympanograms do we have here?
Type A
Right.
on the left, sorry.
Type A,
AD in essence.
yes, AD. Look at that admittance there, 5.4 on a 5-month-old. And then our right ear.
I mean, I would say that's a B.
No, C.
A C, sorry, pardon me. C.
Yeah, yep, C. No, awesome. You guys did awesome. And now with little kids this young, we use a different probe tone, and I put the highlight there for it. It's 1K just for that resonance and that much smaller ear canal. For an adult, it's 226 hertz, but this is 1K. So moving along, this baby came in and we ended up doing once again DPOAEs, and this is for rescreen and ABR, which we won't get into today. But the day that I saw her, our very, very large AD tympanogram turned into this. What do we have here? And I'll
No,
bring
I
that-
have no idea what that is.
So on the right, we have a very nice type A. There's no more negative pressure in that ear. On the left, we have a bifid or bipedal tympanogram. Okay. So per one of my textbooks, when you have a bifid tympanogram, it's a sign of a mass dominated ear. So it can be problems with the acicular chain, such as a discontinuity. Whereas if you, we're seeing something like growth that shouldn't be there, like a bunch of fluid or a cholesteatoma. And I know I'm preaching to the choir here because you guys know a lot more about this than I do. But then, we would expect more flattened and rounded. But in this case, this little baby ended up having a full conductive loss. And she ended up having, after imaging was found, ossicular chain discontinuity. So she was fitted with a soft band, a Baja, and her parents are super on top of it. They're handling all the things. They have programs for kids with hearing impairment in this area of Michigan called Early On, where the school system's involved, and they're helping the parents out every step of the way. So at the time of that rescreen, where we found that bifid or bipedal, whatever terminology you like to use, tympanogram, and then ultimately ended up doing the rest of the testing. ENT recommended imaging to the parents to find out what the root cause was. They wanted to wait until she was 1. They just didn't want to expose her to, radiation, CT, what have you. I understand. And so they did. And the checkup was that she did end up having a discontinuity of the ossicular chain. So really, really interesting, particularly in a child that young. But I have never seen one since. For a bipedal TIMP, so I just wanted to include it because I thought it was interesting.
That is so cool. I wouldn't have known what that was at all. No idea.
Yeah, I don't think I've ever seen that before. Certainly not an adult. And I see by far way more adults than kids, but that's interesting. It'd be interesting to know if you did that over time. Is that repeatable, or do those peaks change much over time? Interesting.
Yeah, I've never seen it either. I'm reading about it here, and it says that excuse me, in newborns you can see it, but if it persists. And how old is this child?
This child at that time was 5 months.
5 months.
She's now 2. Yeah.
2. Did it go away when she was 2? They're just saying that Oh, you said there was a mass. They do say it could be mass induced, but
Mhm.
yeah, that's very interesting. I haven't seen that either.
Yeah, my preceptor at the time said that that was a unicorn tympanogram. It's a once in a career tympanogram if you see it. So, yeah, it was a cool case. I don't know if it's resolved. I'm not sure what the parents' plan is. I'm no longer at that site of rotation, but you know, I was able to you know, find out that she was fitted with a Baha on that side of softband because she's too young for surgery at this point in time. And you know, that they did end up completing imaging and it was a discontinuity of this ossicular chain. So just really interesting tympanogram. They're out there.
Yeah. Yeah. Thanks for bringing that to our attention. I've never seen that before. That's interesting. Yeah. Very cool. Yeah, they say that the frequency at which it emits tympanogram becomes double peaked is roughly equivalent to the resonant frequency of the middle ear.
Yeah, interesting. Really cool. I also have a 7:30. I got to jump off, but thanks
Yeah,
very much
great.
for discussion. Nice to see you all.
Great. Nice. Great. Thanks, Brad. Good to see you.
Thank you. Thanks.
Have a good one. Yeah.
Thank you.
Thank you, Corey, for the cases. All right, guys. Well,
My
next week we'll come up next week we'll figure out what else we're gonna do. We did a bunch of audiology the last few weeks. So if you guys have an interesting case, I want to make sure you guys jump in and present. I don't know, Peter or Luisa, if you guys have seen any interesting cases recently. We can
Well, I don't know if it's too interesting, but the whole otology team was here until 7 p.m. last night. We did a bone bridge on an adult
yeah.
patient, and normally, you know, we went in and we were ready for a 1-hour procedure, and the anesthetist had a huge drama about the intubation, but they managed to fiber optic nasal intubate her. And then we're like, oh, finally, we're going to do this great quick procedure. It's going to be wonderful. And then it was a nightmare. She had a previous surgical scar on the side that we were operating on, but her skin was adequate on that side, whereas on the contralateral side, she'd actually had a Baha there, which needed removal previously, and the skin coverage on that side was very thin, so she wasn't for bone bridge placement on the side the Baha had been. So we opted to place it on the other side, but then she'd also had this long incision, so she had quite a bit of adhesions, and also her skull at the point where we decided to place it was kind of the shape of the skull, and we were just it ended up being like a million hour procedure from something, you know, and we just, it was such a fiddle. It was like drilling it bigger and then changing the shape and then flipping it up, flipping it down. So it gave me a whole new respect for bone bridges. So like,
you said it was a Med-El bone bridge.
Yeah.
It was a bone bridge. Yeah, bone bridge is not straightforward because you got to drill a well. You got to drill so you know what a bowling ball is, right? It's almost like a hole in a bowling ball, right? Yeah. And so you worry about dura. You got to have it thick enough to get, otherwise you get down to dura, so you can get a CSF leak. And then if it's canted on the side of the head, you have to use these. Did you have to use lifts? They call them lifts. The little inserts that go under the tabs that sort of try to equalize it, balance it out. So maybe one has a lift, the other doesn't. They're not easy to put in. They're really not. I mean, if the circumstances are good, they're fine. No scarring, flatter skull, thick. You got a thick amount of bone that you can, you know, recess well without worry about dural tears. Yeah, but they're not easy. So yeah. The ones that are a lot easier to put in are osseas. They're made by Cochlear Corporation, where you're just putting in a small abutment or implant that then you screw the device into, and that's like a 4 millimeter well. It's like 4x4. It's not like the big bowling ball finger hole that you have to do for the Med-El. Oh yeah, I know. So not easy. So just goes to show you that there's no trivial surgeries, right? You never want to underestimate anything. Something that you might think in your mind, oh, this is going to take an hour. those are always the one that take 3 hours.
No. No,
It's
it
just
was
how it
wild.
goes. Yeah, yeah.
You have to tell Prof you have passed your
Or
exam.
if you have to go, please don't. You don't feel like you stick around. You're welcome to stick around, but if you have to go, please don't feel like you have to. Thanks so much. Really appreciate your time. That was
My
wonderful.
pleasure. My pleasure.
Have a-
Hopefully it was helpful. All
Yeah,
right.
that was
Take care,
great.
you
Thanks
guys.
a lot.
That was great. Thank you.
See you later. Take it easy. Thank you.
Peter said I passed my finals, Prof.
Oh,
I'm done.
hey.
Yay!
Not a surprise. No, yeah, not surprised. That's wonderful. Congratulations. That's wonderful.
I might
That's
come visit you for an observership at some point if you'll have me. I'll just use this
Yeah.
opportunity to find myself.
Yeah, that's wonderful. It's a nice feeling though, huh?
Yeah, it's great.
Like a
It's
weight
really
off your shoulders, right? Yeah,
Yeah.
that's wonderful. Yeah. Well, I'll be out there in about a month. I'll be seeing you guys here in just about a month.
Cool.
Yeah, I'll be there for the week, and then Peter we'll be spending a lot of time in the bone lab drilling. I'm doing a bunch of lectures, and then there's the ENT Congress that weekend.
Yes.
So that's gonna be a great week. So I'll be seeing you guys within a month. So yeah, so excited to come back out. This will be wonderful. So next week we'll work on a topic. I'd like to have you guys maybe present something too. So we're going back and forth, so you guys have an opportunity. So maybe think about a case that you might want to talk about or a topic. We'll kind of we'll continue with some, obviously intertwining audiology with all this stuff. It's really important to be thinking about those things, but and then Peter will probably do a little bit of ABR for you. I mean, I don't know. In Ghana, were you seeing any ABRs? Are you doing ABRs in kids at all or in adults?
So it's been done at the where I trained, Hollywood.
Okay.
It's the Accra, so.
Okay. So we'll probably cover some of that in the next few weeks then. Just a refresher on that too. But yeah, okay. Great. All right, guys. Have a great weekend.
Prof.
Did you?
Tasneem she just had meetings, so she apologizes for
Oh,
not being
that's okay.
Yeah.
No problem. No, I know Fridays are tough for her. She's got a lot going on, so I get it. No problem at all. So,
That's Prof.
all right. Good to see you guys. Have a good weekend. Take care.